Good morning and welcome to TRIO Maryland, the virtual transplant journey. We look forward to a program filled with great information and takeaways for everyone participating. To open the event, please welcome Marty Marin, President and co-founder of TRIO Maryland, and Charlie Alexander, President and CEO of the Living Legacy Foundation.
Good morning and welcome to TRIO Maryland's first virtual transplant conference. And we are so glad to see all of you here today for this educational event. I am Marty Marin, the president and the co-founder of the Maryland chapter of TRIO, which stands for Transplant Recipients International Organization. I am also a liver recipient, November 2009, from the Johns Hopkins Hospital. And I will forever be grateful to my donor for this second chance at life. After my transplant, I started volunteering at the Johns Hopkins Hospital and at the Living Legacy Foundation. And it was during this time that we were able to establish the Maryland chapter of TRIO. Our mission is to connect transplant recipients with one another, to provide education on transplant topics, and by offering non-clinical support, we complement the services of our healthcare professionals. We offer monthly educational meetings, and we have hosted 5 in-person conferences over the last 8 years. Please check us out on our website at www.triomaryland.org. And now for the thank yous. I would like to thank the TRIO Maryland Board of Directors and Drio, our web hosting company, for all that they did to create this event. I would like to thank our partner, the Living Legacy Foundation, and our hospital partners, Johns Hopkins Hospital, and the University of Maryland Medical Center. I would also like to thank the presenters for all their time and for sharing their knowledge on these very important transplant topics. We have wonderful sponsors that are involved with our transplant community, and we wouldn't be here today without their support. Thank you to all our sponsors. Don't forget to check out our sponsors and their websites. You'll find them on our sponsor tab on our registration platform. Thank you again, and we hope today is informative, educational, and helpful as you make your transplant journey. Good morning and have a good day.
Hello, my name is Charlie Alexander. I'm the president and CEO here at the Living Legacy Foundation of Maryland. I want to welcome all of the TRIO members to this event and just say a few words on behalf of the Organ Recovery Program serving most of the state of Maryland here. The TRIO has been a valuable partner of ours for years. There's no more compelling message ever than to hear those patients and their families who've been impacted by the gift of organ and tissue donation. You are our great stewards, you're our great spokespeople, and we get up every day and come to work in service of you and your families. Now, the Living Legacy Foundation is the organ recovery program here, again, working most closely with Johns Hopkins Hospital and the University of Maryland Medical Center. So we're working with families who are arguably going through some of the worst days of their lives, faced with the prospects of saying yes to organ and tissue donation. And we are thinking of you every time we sit with those families, advocating for our waiting recipients and serving our donor families. So thank you for what you do. Thank you for the courage it takes to be an organ and tissue transplant recipient. I have a longtime friend of mine all the way back to days of middle school who received a kidney and pancreas transplant, and she reminded me every day following her transplant that being a recipient isn't for sissies. And I watched her work hard to be a perfect steward of that gift and honor that donor family. And to me, that's humbling, and that really defines why we do what we do. So thank you again for being a part of this day. I hope you learn a lot and you can share a lot with others going through the same transplant journey that you're going through. And again, best wishes for good health and a great 2021. Thank you.
What a great introduction and a great way to kick off the 2021 event. TRIO Maryland is excited to be bringing you this conference virtually. A quick reminder about your individual schedule. Please remember that the sessions for which you registered will all have separate Zoom links. You can log into the links 5 minutes before the session starts. If you need support, please text 410-635-0229. The first session today is transplant medication costs and prescription insurance coverage. Please post your questions in the Q&A tab, and we'll share with our speaker after the presentation as time allows. Our speaker, Dr. Rachel Curtis, earned her Doctor of Pharmacy degree from the University of Pittsburgh School of Pharmacy. She is currently completing her second year of postgraduate pharmacy training in solid organ transplant at the Johns Hopkins Hospital. Welcome, Dr. Curtis.
Thank you so much for that introduction, Michelle. Give me a second while I get my slides pulled up. All right. Thank you so much for having me here today. I'm really excited to be here and to talk a little bit about medication costs and prescription insurance coverage. Just a couple disclaimers. Prescription insurance coverage in our country is exceedingly complex. This topic and presentation today will not be all inclusive, but is really meant to just be an overview of the different types of prescription insurance coverage available, and also really serve as a reference for you moving forward when you're navigating, affording, and paying for your prescription medications. A couple of learning objectives for today's presentation. First, I'll start by briefly reviewing common post-transplant medications. Nothing too in-depth, as I'm sure many of you are familiar with the medications used. Next, I'll review the different types of medication insurance coverage and how they are similar and how they are different. And lastly, I'll just spend a little bit of time explaining additional assistance options that are available for patients when the prescription medications are unaffordable. So I'm sure some, if not all of you, likely already know the importance of taking your medications following your transplant. But I would be remiss if I did not spend a minute reviewing the importance of this and to explain that taking your transplant medications following a transplant is so important to prevent the rejection of your new organ. Preventing rejection will really extend and sustain your quality of life. This is also why it's important to try and understand and navigate the complex topic of insurance coverage in our country. To briefly review some of the types of medications used following transplant, I've broken them into 3 different groups. The first are anti-rejection, or also called immunosuppressant medications, and these are the medications that help prevent rejection of a transplanted organ. Next are the anti-infective medications, and these are used to help prevent infections following transplant. As we know, transplant recipients are at an increased risk of developing certain infections. The last group of medications I've just titled as other, and this is just to help capture that transplant recipients often have other medications on top of anti-rejection and anti-infective medications to help with other symptoms or other chronic conditions they may have, such as high blood pressure, stomach upset, high cholesterol, or potentially high blood sugars. I won't be talking much today about these other medications, but just wanted to include it for completeness. Most commonly, patients are started on 3 different anti-rejection or immunosuppressive medications following their transplant. And most patients will remain on some form of an anti-rejection medication lifelong. However, this will really depend on your transplant center as well as your transplant providers. And this is also going to be a patient-specific decision. So I've listed here the 3 most commonly used anti-rejection medications across the country, some of you which I'm sure are familiar with. Before moving any further in the presentation, I thought it was really important to clarify between the different types of medication cost that can be referred to. So when you see the cost listed for a medication, it's first important to determine whether that cost is the cash price of a medication or whether it's your copayment. So the difference between the cash price and a copayment really comes down to if you have prescription insurance coverage. So the cash price refers to a price of a medication without any insurance coverage, so just the plain cost. And as you can imagine, the cash price of medications is often much higher than the copayment of a medication. A copayment is the leftover amount or leftover cost that you would be responsible for paying for a medication after your prescription insurance covers a portion of the medication cost. As you can imagine, copayments are usually lower than the cash price of medications. It's important to know that copayments for medications are largely variable. So it's going to depend on the type of medication you're being prescribed, as well as your specific prescription drug insurance. I'll now spend some time just briefly reviewing the 3 anti-rejection medications that I previously listed. Again, this information is not all inclusive, but are just some important points about each of these medications. I've listed next to each medication the cash price of each medication, so I wanted to point that out, as this will not potentially be the price that you would pay for these medications. It's again going to depend on your specific insurance coverage. So the first medication is Tacrolimus or Prograph. Tacrolimus is one of the most important anti-rejection medications out of the 3, and it works really by stopping our immune system cells from replicating and working, and by doing that prevents rejection. Tacrolimus does require routine blood level monitoring, and some notable side effects include usually headache, potentially tremor, and long-term can cause elevations in your blood pressure, your blood sugar, as well as potentially damage to your kidney. The next medication is Mycophenolate Muscleteal or Celcept. This works similarly to Tacrolimus in that it's working again by stopping your immune system cells from replicating and working appropriately. There's no blood level monitoring required for mycophenolate, and most common side effects are related to your stomach, so usually stomach upset, nausea, and potentially diarrhea. The last anti-rejection medication is prednisone. So prednisone is a steroid, and steroids can be used for lots of different conditions, but they do work in a way to, again, help stop our immune cells from replicating. Common side effects reported from prednisone do include high blood sugars, increases in your blood pressure over time, and potentially weight gain or changes in your mood and feeling more irritable than normal. In addition to the 3 anti-rejection medications, anti-infective medications are equally as important to help prevent the development of infection following transplant. So there are commonly 3 different types of anti-infective medications used following transplant: 1 to protect you against certain bacteria, 1 to protect you against certain fungi, and 1 to protect you against certain viruses. So I've listed here examples of all 3 of these types of medications. These are the anti-infective medications most commonly used here at the Johns Hopkins Hospital following transplantation. But again, this is going to be specific to each patient and potentially each transplant center. So now we'll transition into talking and thinking about the different types of medication insurance coverage. You may be wondering first, wow, transplant seems so expensive and how will I pay for all of these medications? So insurance coverage and financial clearance is part of the pre-transplantation workup. But if a patient receives financial clearance for transplantation, this often more refers to the surgery and the hospitalization itself. And just because someone does receive financial clearance doesn't necessarily mean that their medications are going to be affordable for them moving forward after transplantation. The costs of medications following transplantation are really going to depend, again, on your specific prescription insurance plan and the medication. Each insurance coverage plan does have what we call a formulary. So this is just a list of prescription drugs that insurance plan has decided that they're going to cover or offer prescription drug benefits for. So this will vary between plan, and we'll talk a little bit more about formularies in detail in a minute or so. One of the most important and I think most confusing parts when discussing prescription drug insurance are the different types of insurance. So the types of insurance that you can have really will determine how much your medications will be covered, how much you have to pay as a copayment each month, and additionally, if you'll be eligible for any additional patient assistance programs if you can't afford your medication. So I've listed here on the slide the different types of prescription drug insurance available. But there are really two different types of insurance, or two kind of buckets of insurance is how I like to think of it. So the first is insurance issued by private insurance companies, and we refer to this as commercial insurance. And the second is insurance issued by government funded programs. So this would include both Medicare and Medicaid. As I mentioned, most insurance companies will have what we call a formulary. So formularies, again, are just a list of prescription drugs that the insurance company has decided that they're going to offer prescription drug benefits for. Within a formulary, they're often divided into what we call then a tier system. So drugs can be placed into different tiers. Usually tiers range from 1 to 3 or 1 to 4 different tiers. And drugs are placed into the tier groups really based on how common they are and how expensive they are. So you can see that in tier 1, this includes most common generic drugs. And for patients, this is likely going to mean that their copay will be lower if the medication is included in the first tier. As you move up the tiers, medications usually become less common, more expensive, and meaning that the copay for the medication will also be higher. So medications in tier 3 and 4 are usually medications that might not be very common, might be rarely used, and are potentially unique or very high cost drugs. So the first type of insurance I wanted to talk about today is commercial insurance. So as I mentioned, this is insurance that is issued by private insurance companies. And this is the type of insurance that is being referred to when someone gets insurance through their employer. For example, some private insurance companies include CVS Caremark, Aetna, and Blue Cross Blue Shield, to name some common ones. Commonly, commercial insurance is less restrictive as compared to other prescription insurance plans, meaning that they do cover a larger variety of medications to be available to patients. This is an example of a commercial insurance card. So when you enroll for commercial or private insurance, you'll be sent an insurance card in the mail. So this is just an example, and I wanted to use this just to point out some important points on an insurance card that would be helpful for you in terms of your prescription drug copayments. So if you were to call the pharmacy about a new prescription, you're wondering what your copayment might be. Some things that the pharmacist might ask you for off this card, I've highlighted here. So things including the RX BIN number, the RX PCN, and the RX group number, as well as a family or a member ID would be the things most commonly a pharmacist would ask for. You can see that this card also includes prices for some different types of doctor visits. And this is really going to be variable depending on your insurance plan. But some cards do also put this on the card. So again, this is just an example, and each insurance card will be different depending on the plan benefits. So next, we'll transition into talking about Medicare. Medicare can be complex, but for the very basics, Medicare is a federally funded government program designed to provide health insurance coverage for individuals who are 65 years and older or who have a disability. Medicare is broken up into different parts, and these parts range from Part A to Part D, but Parts B and D are specifically the parts that can deal with prescription drug insurance. So in general, Medicare Part B covers the majority of medical care outside of medication. So things like your doctor's office visits, medical equipment, things like that. But it can also cover transplant medications for kidney transplant recipients. Medicare Part D specifically refers to plans within Medicare that cover prescription drug insurance. So we'll talk a little bit in detail about both of these different Medicare parts. So in the year 2000, Congress passed a law that for patients who are under 65 years of age, who would normally not be eligible for Medicare, but who are kidney transplant recipients, that they would qualify for coverage of their anti-rejection or immunosuppressant medications following their kidney transplant, and that this coverage would last for 36 months. So you may be thinking the same thing as me is, well, why only 36 months and what happens after 36 months, which I think is a logical thought. And a lot of people felt the same way. And for the last, actually, I think 10 years or so, people and organizations have been working to pass the Comprehensive Immunosuppressive Drug Coverage for Kidney Transplant Patients Act of 2019, also commonly referred to as the Immuno Bill. And in very exciting news, the Immuno Bill was passed in just December of last year. And this bill was designed to extend this Medicare coverage of anti-rejection or immunosuppressive drugs for kidney transplant recipients past that 36-month mark. So really through the duration of the transplanted organ. And so this is a really exciting thing that just happened last year that I wanted to share. And last I checked, even though this bill has passed, it has not been put into place yet, but hopefully, fingers crossed, this can start to come into effect in the next couple months or years. Just like I shared an example of a commercial or private insurance card, I also just wanted to share an example of what a Medicare card can look like. So notably, Medicare cards are usually always red, white, and blue. So if you enroll in Medicare, you'll again receive a Medicare card in the mail, and this would be important to carry around with you. So as I mentioned, Medicare Part B can pay for part of immunosuppressants for kidney transplant recipients. In this case, there is cost sharing that occurs in terms of how much you would be responsible for paying for your immunosuppressants. And we refer to this as the 80-20% rule. So this means that Medicare pays for 80% of the cost of the medication, and you would be responsible for 20% of the cost. So your copayment is going to be 20% of however much the cost is. And somewhat detailed in that some patients might think that their 20% co-payment might be covered by another type of insurance, like a supplemental insurance plan. However, unless this plan is grouped with Medicare Part B, oftentimes you can't really split the co-payment, in this case, to result in a lower copay. Because I think this can be a little bit tricky to think through in terms of your actual copayment, I thought we'd walk through an example to think for if someone had Medicare Part B. So we'll briefly talk about Shelly, patient Shelly. Shelly just had a kidney transplantation and she's almost ready to be discharged from the hospital. She's getting all of her medications ready. She does have Medicare Part B, which will cover 80% of the cost of her immunosuppressants. The total cost of one of her immunosuppressants, Mycophenolate Muscleteal, is $120. So how much will Shelly's copay? So I think you might be able to use the chat function if someone would be able to share how much they think the copayment for the mycophenolate would be. If not, we can walk through it here in a minute.
Looks like Rachel's having a few technical difficulties. We also have Brandon Keith on. Brandon, are you available maybe to answer a few of the questions while Rachel gets herself situated?
Certainly, I certainly can. What questions can I answer?
Well, do you want to, I know Juan had an open question about the new law that was introduced for Medicare. If you can possibly answer that one for him.
Sure. So it looks like a question from Juan. The question was, a new law was introduced for Medicare to pay for immunosuppressants for the life of the transplant. How can an existing patient who does not have or qualify for Medicare can benefit from this new law. So, and then I think I see a couple questions maybe in the chat as well. But to answer that question, so my understanding is this new law is extending the coverage. I know that, when I first signed on to being a transplant pharmacist a couple years ago, and learning that the coverage ends at 3 years, that just seemed very wild to me. I thought, well, what will people do, when they lose that 80% coverage? I'm sure a lot of people will then start scrambling to find some other sort of insurance coverage, and what the cost of that will be and what the coverage can vary greatly. But for this law, I'm not so sure that it is going to assist those who did not already have Medicare. I think it's more of an extension for those who did qualify for Medicare based on different reasons, whether that be end-stage renal disease, on dialysis, above a certain age, is my understanding of the law.
Great, thank you, Brandon. Looks like we're getting Rachel back. I didn't know if there we go. Yes, we can hear you. Brandon took a question or two while you were resetting, so we're good.
Thank you for your patience. Always on our toes these days with everything being virtual. Thanks, Brandon, for jumping in and sharing your expertise. So I think we left off here. I had asked if anyone wanted to share what they think the copayment for the mycophenolate would be. I did see some things in the chat here for $24 as the copayment, and so that is correct. So if we know the total cost of a drug, we can just do 80% of that cost, and we know that's the portion that Medicare Part B will pay for, and then 20% of that would be your copayment. So in this case, Shelley would pay $24 for her mycophenolate. Awesome. All right, let's then move on, and fingers crossed for no more technical difficulties here. All right, so now we'll transition into thinking about Medicare Part D. So Medicare Part D is different than Part B in that it is designed specifically to cover medications for prescription drug insurance. It's important to note that, again, coverage was going to be highly variable depending on your Part D plan. So they're going to differ between the different plans. Generally, again, Medicare Part D is for patients greater than 65 years of age, but can apply to patients with disabilities. And some caveats are that patients can qualify if they have end-stage renal disease, if they've been on dialysis, or if they have received a kidney transplant. It's important to note, and I wanted to point out that Medicare Part D is voluntary, a part of Medicare that's voluntary. So you have to enroll specifically in a Part D plan when you enroll in Medicare in order to get those prescription insurance benefits. And I think a lot of people have heard the term donut hole, or often called the coverage gap as well. And this is part of Medicare Part D. So we're going to talk a little bit about the different benefit stages of Part D. And this includes the donut hole, just to think through how you might be in a different stage of Medicare and how that might change your copayment for medications. The first stage of Medicare Part D is meeting your deductible. So when you sign up for Medicare and when the benefit year starts, you're going to pay the full cost of your prescription drugs until the spending on your prescription drugs add up to the amount of the deductible that the plan has set. So if your plan has set a $0 deductible, you've already met that by not spending any money. And so you will skip actually straight to the next stage. Again, keep in mind that not all medications on a plan may go towards your deductible. So the plan can really determine what medications, what costs will go towards that. And again, may pick drugs from certain specific tiers that are going to go towards your deductible. Once you've met your deductible, you enter the initial coverage phase. So this is when your plan will pay for a portion of your prescription drug insurance. Again, if that medication is covered on the plan's formulary or list of covered drugs. And this will begin again as soon as you have the total of the prescription payments you've made equals the deductible. And this is when you'll have a co-payment, or really that set dollar amount for the prescription. And there's the set percent of the prescription that Medicare has decided they will cover. The next phase after initial coverage is the coverage gap, also often referred to as the donut hole. So not everyone will enter the coverage gap or the donut hole, but this occurs when the amount you've spent on prescription drugs and the amount that your plan has spent on prescription drugs reaches a specific coverage limit, again, set by Medicare the Part D plan itself. So once you then enter the donut hole, you become responsible for paying about 25% of the plan's cost for medications. So keep in mind that this is actually going to potentially be very expensive, and is really going to depend on the specific drugs and may differ based on brand name versus generic drugs. So it's important, if you are in the coverage gap or donut hole, to calculate the amount you would owe kind of for each medication to see which one might be actually cheapest for you. And then you exit the donut hole or the coverage gap when your total out-of-pocket costs on all covered drugs reaches a certain, again, limit set by the Part D plan itself. Most recently, I saw that this figure was about $4,100 is the cost. So once you've spent this out of pocket, you will enter the catastrophic coverage phase. And in that case, Medicare kicks in and starts to cover more of the prescription drug costs, so about 95%. And you would have a much lower copayment for all prescription drug insurance. And then if you enter catastrophic coverage, you would remain in this phase really until the end of the plan year. And then once the plan year resets, you kind of start at the first plan stage. All right, so now that I've reviewed a little bit about Medicare Part B and D, again, not all inclusive, as Medicare can be exceedingly complex, but I did want to just briefly touch on Medicaid as an option for prescription drug insurance. So Medicaid is technically a government type funded insurance, but is operated on a state by state level. So it's medical assistance available in a state, again, available to those with low income or if you were to have a disability. Unfortunately, Medicaid is usually the most restrictive of all of insurance drug plans, meaning that it doesn't cover a wide variety of prescription medications. And it's important to note that you must reapply for Medicaid at regular intervals. So if you need Medicaid on a continual basis, you need to be reapplying. I just, for completeness, wanted to also share an example of a Medicaid card. So just like Medicare and private insurance, if you are enrolled in Medicaid, you would get a card in the mail, but each card's really going to look different depending on what state you're in, as it is a state issued type of program. So this is just an example of what a Maryland Medicaid card looks like, again, going to vary depending on what state you're in. So we've reviewed the different types of prescription drug insurance. That's important when thinking about your drug costs and what your insurance plan offers. Another piece of terminology I wanted to briefly review is a prior authorization. So prior authorizations are when health insurance companies make your healthcare transplant provider obtain a type of special approval in order for the insurance to qualify a patient for any type of insurance coverage for a medication. And kind of without that specific approval, that medication really probably would not be covered and be very expensive for a patient. So this often requires your healthcare transplant provider to provide some type of rationale via paperwork, via the phone, as to why one medication is required over another. And this is usually when we need a more expensive or less common medication when there is a cheaper medication available. So really, prior authorizations are a cost control type process put in place by insurance companies. However, can be a large source, I think, of frustration and delays when trying to get insurance drug coverage, and something that our outpatient transplant pharmacy team here at Johns Hopkins works a lot on closely with the transplant providers. And this is common, I think, for transplant patients, again, because we are maybe using medications that aren't common in other patient populations, but we know that transplant patients need. All right, lastly, I'm going to just spend a couple minutes touching on patient assistant programs for prescription drugs, or what we often refer to as PAP. And so these are really programs that exist to help patients access medications when they are not affordable for them or when they're not covered by insurance. As a disclaimer, patient assistance programs are very complex, and understanding the eligibility requirements takes, I think, a lot of time and practice. So I won't be going too in depth into this, and is more just for a reference for you and for you to also have if you ever need patient assistance, and you can take this, to your transplant provider or your transplant social worker. So thinking through as pharmacists and providers, when patients' medications are unaffordable, we usually think through a couple different steps to determine if they would be eligible for patient assistance. So once we know a medication copay is unaffordable, we first make the determination whether a patient is either uninsured or underinsured. So uninsured is when a patient has no active prescription insurance coverage, and underinsured would mean that a patient has insurance coverage, but their copayments are still not affordable or comfortable for them on a monthly basis. We then would go through deciding if they would be eligible for patient assistance programs. And patient assistance can come in a couple different forms and from a couple different places or organizations. It can come from an insurance company itself or from the actual manufacturer of the drug. And assistance can come in the form of potentially a copay card. So a card that could be called into the pharmacy, you could bring into the pharmacy that would really bring down the cost of that medication or potentially make the medication free. Also, grant programs are another form of assistance, and these are usually made by the drug manufacturer themselves. And they have programs that if patient meets certain eligibility requirements, they can be enrolled and then again, potentially receive discounted or free drug. So these are kind of the steps that as pharmacists, we think through when deciding or helping patients get enrolled in patient assistance programs. Again, this is very complex, done in accordance with transplant providers as well as transplant social workers. But usually we first need to think about what type of prescription drug insurance a patient has, as that will largely determine their eligibility. So do they have a Medicare Part D plan, or also Part B would probably follow similar qualifications, or do they have private commercial insurance? The next step is usually deciding what a patient's household income, annual household income is, as many patient assistant requirements do require an annual household income at certain limits in relation to the federal poverty line. So that is something we might need to find out depending on what type of insurance they have. And then another really tricky part, lastly, is as pharmacists, we then need to think about if the insurance company has approved a brand name version of the medication. And once that's approved and we know the copayment, that's usually what we can apply a patient assistance program, copay card, et cetera, to help bring down the cost. So this is a table actually used by some of the pharmacists here at Johns Hopkins Hospital when thinking through patient assistance programs. It is very complex with a lot of details, so I'm not going to go over it. I really just wanted to include it for your reference. And if you ever would need patient assistance for you to have and work through with your social worker or pharmacist. On the left-hand column, it does include some very common post-transplant medications that can be very unaffordable for patients and that we commonly try to enroll patients in patient assistance programs for, usually brand name medications as well. And so you can see that for patients with Medicare Part D, we usually need to find out what their annual income, household income is, and where that is in regards to the federal poverty limit. And then also thinking through if they had commercial or private insurance, if or not a copay card would be available to help bring that price down. Because this is kind of a complex thought process and something that takes time for pharmacists and social workers to do, I did want to run through a case more just to highlight the kind of steps that we think through. Again, this is complex and not more necessarily just for your reference. So we can talk a little bit about patient KT. He just had a kidney transplant and he's meeting with his pharmacist to discuss his medications, all about them, and also talking about the cost of them. So this patient does require valganciclovir, which is an antiviral medication, for 6 months following his transplant to help protect him against certain viral infections. We find out that his copayment, his 30-day copayment for his valganciclovir or Valsite is going to be $688. And so I think we can all agree that that is a very expensive monthly copay. So when we find this out as a pharmacist, we usually then try to determine whether this patient would be eligible for patient assistance. The first part of that, as I mentioned, is deciding what type of prescription insurance the patient has. So in this case, this patient does have Medicare Part D plan. And then from there, we know that we would want to find out if the patient's household income falls within the certain patient assistance requirements for that medication. So for valganciclovir or Valsite, we do find out that his annual household income is within the patient assistant requirements. And then the last step that we usually need to work with transplant providers with is submitting a prior authorization for the brand name of this drug. So we know that this step hasn't been done. And so we'll often work with the transplant doctors or your transplant providers so that they can submit the prior authorization. And once the prior authorization for the brand name of this medication is approved and we know the copay, then we can pursue application for patient assistance. And so that was done, and that now we know that there's the opportunity to pursue a free copay card for brand name Valsite. So in this case, lots of different steps to work through, but it would really help bring down the cost of the valganciclovir so that this patient is able to take it for that 6 months to protect him against viral infections. All right, so I know that that was a lot of very complex information, and again, not all inclusive, but some take-home points are that insurance in our country is extremely complex and confusing, and I am by no means an expert. I think it's really a team sport. We work very closely with transplant providers and our transplant social workers who are so crucial in helping patients access medications. And really wanted to highlight that if you are in the situation where you find your medications are unaffordable, you're not sure what to do, you're not sure how to navigate it, we always want to encourage you to call your transplant team or your transplant social worker and walk through your different options. And as you all know, I'm sure this is really important so that you can access your transplant medications, which are really going to extend and sustain your quality of life. Lastly, I just included a table of some of the very common post-transplant medications, really just to have as a reference. If you ever needed a list of medications to kind of cross-reference with your own insurance benefits to decide how much your medications might be following transplant, or if you're prescribed a new medication. Just a couple notes, these are cash prices listed here in the third column. And this is just examples of dosing. The dosing for these medications is usually very individual and can vary depending on the patient and the provider and the center. So I wanted really to just include this for your reference moving forward. If you ever need a list of drugs that you think you might be on or that you want to look at with your social worker, you have this here. So that was all I had for today. Thank you so much again for inviting me to speak a little bit about this very complex topic, but I think it is important. Like I said, it really is a team sport. And again, I'm sorry for those technical difficulties. So I thank you all for your patience. I think I have been seeing a lot of questions in the chat. So Michelle, I didn't know how much time we had to talk through some of these.
We have time to talk through questions.
Awesome.
I also want to recognize Dr. Brandon Keith, who's the clinical coordinator for solid organ transplant at the Johns Hopkins Hospital. He's been helping out answer some of the questions while you've been speaking, Rachel.
Oh, awesome. Great.
So let's start. I have for kidney transplant, can one stay on commercial insurance and not be forced onto Medicare? And if so, how?
For specifically kidney transplant?
Yes, it says for kidney transplant. Yes.
Yeah, so I would say that would likely depend on your age and what age you are. So if you're at that 65 cutoff, I'm going to ping this over to Brandon, as he may know specifically once you're over 65, if it's required to be enrolled in Medicare, different parts of Medicare.
Sure. So as far as it being required, I don't know that I can necessarily, and I might have to mute anyone else just because it might cause feedback. But as far as Medicare requiring you to have Medicare, I think it's more about you being eligible. We do have the large majority, I would say, of our kidney transplant patients, they do have Medicare coverage. Many of them do have commercial insurance, and it really just depends on what type of plan you have, and if you have a secondary or supplemental plan, on what the difference is with your medication costs. So I've had some Medicare patients that have very low costs. I have some Medicare patients that have very high costs. It just depends on, if they have a supplemental or not. And the same thing can be said for our commercially insured patients. So I won't say that one is necessarily better. It really depends on what your insurance setup is.
Yeah, that's what I was thinking. Thanks, Brandon. I figured it'd be more of a specific to your type of insurance.
Great, thank you, Brandon. So next we have a question from Melanie. If it has been years since my transplant, may I sign up for Medicare Part D? My private insurance costs are high and it would be nice to lower.
Yeah, I mean, if you're eligible for Medicare Part D, I don't think there's anything, just because you're a transplant recipient, there'd be nothing forcing you specifically to stay with private insurance. So if you're eligible for Medicare, I would encourage you probably first to explore the different options and find out what your costs might be to make sure that they would be lower. But just because you're a transplant recipient, it doesn't mean you automatically have to have commercial or private insurance. We have many patients here at Johns Hopkins who have Medicare. They might have other types of supplemental insurance, but just because you are a transplant recipient, to my knowledge, does not mean you need to have commercial insurance. I didn't know, Brandon, if you had any other details or comments on that.
Sure. Thanks, Rachel. I was going to say, I think one of the best things I heard from what you just said was, I think it's really important for patients to really find out what their costs will be on the Medicare Part D plan. Even though the cost is lower for the cost of the plan, the resulting medication costs that you can experience, particularly if you're on some of the medications that we see are more expensive, like some of your anti-infective medications, depending on what type of anti-rejection or immunosuppressant meds you're on, or things like insulin, they can be very high costs. And one of the things, Rachel, you had in your slides was talking through the different patient assistance programs that are available. And I know things like copay cards, a lot of our Medicare patients legally are not able to use. It can end up being something that you get penalized for later. So that's if the pharmacy, were to do that, which they really shouldn't be. So yeah, definitely things to look into. For some patients, it makes sense, and they can go ahead and convert over and save a lot of money.
Right.
Great, thank you both. So this goes back to the 36-month limit you were speaking about previously. The question was, what about lung transplants recipients and the 36-month limit?
Yeah, I think that this is probably one of the biggest frustrations and concerns about this law. And when I first learned about it, I had the same exact question as to why is this just for kidney transplant recipients and not all of our organ recipients? So it is specifically only for kidney transplant right now. But just like you and just like me, I think there are lots of people that find this frustrating, and hopefully we can work over the next years to try and expand this coverage. I think originally the law specifically had to do with kidney transplant recipients because of the costs associated with Medicare with patients going back on dialysis. And so this law is really to try and offset those costs, because we know that dialysis is very expensive for Medicare and kind of as a country. And so unfortunately, it does not apply to any other organ transplant recipients other than kidney, which I share with you the frustration in that. And to my knowledge, I don't think there's any similar law right now, but I'm really hopeful that kind of as a transplant community, we could continue to advocate for something or potentially expand those Medicare benefits to other transplant recipients.
Thank you. So this came up because someone was asking about COBRA and the expense of COBRA. So one of our attendees noted that during her recovery, her Aflac helped a lot. But she didn't know if you can have Aflac between employers. So that was a question that they wanted to ask of you.
Yeah, I will admit I am not an expert on Aflac or COBRA, so I'm going to ping this to Brandon, see if he has any insight, as he does have a little bit more experience with that than me.
Yeah, so and I'm going back to, because I know the question was just moved since I guess we're answering it live, but for the Aflac coverage, I'll be honest. So while there are a lot of things that we can speak to as the transplant pharmacy group, some of the insurance coverage questions on when the insurance might kick in and how it kicks in, we more so see the result of that, the actual steps on signing up and qualifications and things like that. I'll be honest that we're probably not the best expertise on that. So for that Aflac question, I'd probably, if I had my our transplant social worker Angie on here, I would ping that over to her.
Okay, well, that might be something then perhaps Rachel, someone can email you afterward and you and Brandon can help. So
Definitely,
yeah, absolutely.
Yeah. So our next question is, over the years, I heard that the Doughnut Hole was to gradually close. Is that true?
I have never heard that. I mean, the Doughnut Hole is really going to be specific to you and your plan and your costs. So I guess I don't know specifically what you mean by closing, as far as maybe changing the requirements of Medicare Part D. Right now, I don't believe that that is applicable, and that the stages I went over are still applying. I don't know, Brandon, have you heard anything about that?
I haven't. I know it's been a big concern, similar to the battle with the immuno bill. The Doughnut Hole has been a big battle as well in terms of any major changes. I have not heard anything, and I think it honestly can continue to change, as you said, with each specific insurance plan. But I think that's still something that we're still going to have to tackle on a case-by-case basis.
Great, thank you both. So then we have, is a liver transplant considered a disability? I don't know if the two of you can answer that.
I don't believe that transplantation specifically is considered a disability, as far as I'm thinking about Medicare requirements. I know there are specifics as far as what does qualify you as having a disability. I don't believe that specifically liver transplant would be included in that.
I agree with that as well. I think from a medical standpoint, I think transplant is looked at, very much as a rehabilitation or rehabilitory procedure. Of course, it's a very major abdominal or thoracic surgery. It definitely causes missed days of work, but I think eventually the plan is, or the hope is, for many of our patients, that they'll be able to return to some level of work. But I do know that it is a huge impact on finances from the patients that I speak to. While I'm just, Michelle, while I'm talking, I do see the next question, which I could probably just go ahead and jump in because it's Johns Hopkins specific. It says, after my transplant, the transplant pharmacist talked about how the Johns Hopkins pharmacy tested the efficacy of the drug batches prior to use. Can you refresh me on that? So yes, so that's my team that does that. So whenever you receive a solid organ transplant at our hospital, at the Johns Hopkins Hospital, and there might be some other transplant centers that do this, but we run what are called test claims. So we basically obtain what your prescription insurance is out of your medical chart. We'll also work with our transplant social worker to make sure we're not missing anything. And we have a list of probably the top 50 or so medications. So anti-rejection, anti-infection, insulins, anticoagulants or blood thinners. And we have the typical doses that we see our patients on. We basically kind of almost pretend like we have a prescription, and we run that through your insurance, and then we run it back. And we basically see, are there high costs that maybe Rachel and I need to connect you to patient assistance programs? Or is there what's called a prior authorization, where we need to get special approval from the insurance company in order to have them pay towards the medication? So so that's our process that that we currently do. And then I can probably also knock out the second one, which is, or maybe the second one down, which is for a diabetic who has kidney transplant, how are related prescription costs, diabetic and other conditions handled? It depends on your insurance. So if you have Medicare insurance versus if you have commercial insurance, we're able to bill both. It just depends on which pharmacy we might have to send your prescriptions to at our hospital. But basically for many of our Medicare patients, their medication costs could end up being zero for the diabetic supplies. There are some restrictions, like we might, only be able to allow you to have so many test strips or so many Lancets per 30 days. You'll probably be limited to 30-day supplies, but we can do either one.
Sorry, we have time for a couple more questions. So I'm just gonna move to Juan had a question. He said, Medicare will not pay for immunosuppressants because I'm employed. I was literally told that as long as I have a job, they cannot help me. And then he said his sister, on the other hand, gets full coverage because she's disabled. So I don't know if there's a question in there, Juan, or if you're looking for some advice on next steps since you're employed.
Yeah, I think I can answer that too. So this is the thing. So a lot of times with a lot of our patients, if they have Medicare insurance, it's always a question or concern of, should this insurance be paying 80% of the cost of my medications? And my answer is, if it is set up that way. So depending on if Medicare is primary or secondary is a big thing. So you would need to find that out. Now, if you're fully employed, a lot of times for many of our patients who happen to have Medicare, Medicare may not pay towards the cost of your anti-rejection medications, or it may not, pick up that remaining 20% of cost. It really depends on what's primary, what's secondary, and what's coupled. And again, I'm not the expert on the insurance, just from what I've seen, but that would be where, if you have access to a transplant social worker, someone who can help you with how your insurance is currently set up and either trying to get your plans changed or switched around. I think that's why, because if Medicare sees that you have a primary insurance, which is through your employer, then they're going to say, oh no, our hands are up. We can't do anything. We're not going to pay because you already have insurance. And I'm sure it's still very expensive, unfortunately. But, unfortunately, the insurance companies there's not really a subjective nature to what they do.
Okay, I'm going to take one last live question, and then Rachel, I'm going to ask you to share your email address for anyone else who would like to reach out, since we have a lot of questions and unfortunately not enough time to get to all of them. So the question is, when does Part B coverage kick in over Part D?
So I think it's more of a question, or more of when does Part D kick in over Part B? Brandon, would you agree?
So yeah, again, I think it definitely is going to depend on how your insurance is set up. And in terms of kicking in, I will say that typically the way that your insurance is set up prior to transplant, for the most part, I usually see that usually doesn't change, but so much. I have seen instances where it will flip over after the insurance company has been notified that you have been transplanted. But again, very specific patient situation. I know that we're running out of time. I'm going to try to answer, if I can, any questions that are still in the Q&A, or Rachel and I, we work together closely. We can follow up with you via email. But thank you everyone for your questions.
Yeah,
go ahead, Rachel, if you can share your email, that'd be wonderful.
Yeah, absolutely. I'll share my email now. So feel free to email me and Brandon with any of these specific questions. Like I said, I work closely with Brandon and the other outpatient transplant pharmacists, as well as our transplant social workers, who again are also really experts in this and help us closely every day to navigate some of those more complex situations. So I just sent my email. Is everyone able to see it?
Yes, you should see it in the chat. rcardis1@jhmi.edu. It is definitely in the chat, so look for that and reach out to Rachel. I want to thank both Rachel and Brandon. You guys have been fabulous answering all the questions. Great information, great insights. I want to remind everyone that our next sessions will begin at 10:15. Make sure to check your email for the correct Zoom link. You can also go to the website and find it there as well. If you want to connect with other participants, we will have a general meeting session, meeting room open, and I am adding that Zoom login or access to the chat. So you can log into that Zoom link, and the room will be open until 12 o'clock Eastern Daylight Time for you to interact with others, make connections, and hopefully get any questions or things answered that you need. And also please visit the TRIO Maryland website, triomaryland.org, to learn more about TRIO Maryland. And you can also visit the event website through that link for more information on the sponsors who have generously helped to support this event this year. Thank you, Dr. Cardis. Thank you, Brandon. And have a good day. Enjoy the rest of the session.
Thank you so much. Have a great one.
Thanks, everyone.